Imagine you are looking at a patient who walks into your clinic with a painless swelling in the front of the neck. At first glance, it may seem harmless, but as we begin to connect clinical findings with pathology, we uncover one of the most important and commonly tested thyroid malignancies, papillary thyroid carcinoma. Now, let's decode this entire image step by step in a smooth, story-like flow so that every visual element becomes clinically meaningful and easy to remember. We begin on the left side of the image, which focuses on the gross pathology. The origin of papillary thyroid carcinoma is clearly shown. This tumor arises from the thyroid follicular epithelial cells. These are the same cells responsible for producing thyroid hormones, which means this cancer is derived from a well-differentiated epithelial lineage. Because of this origin, the tumor often retains some structural organization, which explains many of its microscopic features later on. The diagram of the thyroid gland shows both lobes, with the trachea centrally placed, helping you orient the anatomy. This is important because tumor expansion or invasion can affect nearby structures like the trachea and recurrent laryngeal nerve. Now focus on the appearance of the tumor itself. Grossly, papillary thyroid carcinoma typically presents as a firm, grayish-white nodule. The firmness comes from fibrosis within the tumor, and the gray-white color reflects its cellular composition. Notice that the boundaries are not well defined. This indicates an infiltrative nature, meaning the tumor doesn't respect normal tissue planes. When the cut surface is shown, you can see fine papillary projections, giving it a granular appearance. These tiny projections are not random. They correspond to the papillae that define this tumor histologically. Another critical feature shown is multifocality. Multiple small satellite nodules are commonly seen in papillary carcinoma, especially within the same lobe or even bilaterally. This is clinically important because it influences surgical planning, often requiring total thyroidectomy rather than a limited resection. You also see cystic degeneration, which occurs due to tumor necrosis or degeneration over time. Additionally, extrathyroidal extension is highlighted. This is when the tumor invades beyond the thyroid capsule into surrounding structures like muscles or even the trachea. This feature significantly impacts prognosis and staging. Now shift your attention to the central summary panel, which connects pathology with clinical medicine. The clinical presentation is typically subtle. Most patients are asymptomatic and present with a painless neck lump. However, as the tumor grows or invades nearby structures, symptoms like hoarseness can develop due to involvement of the recurrent laryngeal nerve. Dysphagia may occur if the tumor becomes large enough to compress the esophagus. These are red flags that suggest progression. The key histological findings listed here act as a bridge to the microscopic image. The presence of true papillae with fibrovascular cores is essential. These are finger-like projections lined by tumor cells, with a central core containing blood vessels and connective tissue. Another hallmark is the unique nuclear features. These are so characteristic that they are often considered diagnostic even in the absence of clear papillae. Multifocality is again emphasized, reinforcing its importance both grossly and microscopically. Next, the prognostic factors section tells you what really matters in patient outcomes. Age is one of the most important predictors. Patients younger than 55 generally have an excellent prognosis. Tumor size also plays a role, with larger tumors having a higher risk of spread. Extrathyroidal extension worsens prognosis because it indicates aggressive behavior. Interestingly, nodal metastasis is very common in papillary carcinoma, especially to cervical lymph nodes, but unlike many cancers, this does not drastically worsen survival. It is often still very treatable. Now move to the right side of the image, where the microscopic pathology is beautifully illustrated. This is where papillary thyroid carcinoma truly reveals its identity. The architecture shows true papillae with branching, finger-like projections. Each papilla contains a fibrovascular core, which is essential for diagnosis. You also see areas of sclerosis and calcification. One of the most iconic features here is the presence of Psammoma bodies. These are concentric, laminated calcifications that appear like tiny onion rings under the microscope. Their presence is highly suggestive of papillary carcinoma and often results from necrosis and calcification of papillary tips. Now focus on the nuclei of the tumor cells. This is the most important diagnostic clue. The nuclei have a ground glass appearance, often described as Orphan Annie eye nuclei. This occurs because the chromatin is finely dispersed, giving a clear, empty look. In addition, you see nuclear grooves, which are longitudinal indentations in the nuclear membrane, making the nucleus look like it has a slit. Another hallmark is intranuclear cytoplasmic pseudoinclusions. These occur when cytoplasm invaginates into the nucleus, creating the illusion of inclusion bodies. These nuclear features are so characteristic that even if papillary structures are absent, their presence strongly supports the diagnosis. Finally, at the bottom, the image summarizes the histologic variants of papillary thyroid carcinoma. The classic variant shows typical papillae and nuclear features. The follicular variant, however, grows in a follicular pattern rather than papillary, but still retains the same nuclear characteristics. This is a common exam trap. The tall cell variant is more aggressive, with cells that are at least 3 times taller than they are wide, indicating a worse prognosis. The solid or trabecular variant also suggests a more aggressive course with a different growth pattern. So, when you put everything together, papillary thyroid carcinoma becomes a beautifully logical diagnosis. A tumor arising from follicular cells, presenting as a painless thyroid nodule, showing multifocal gray-white infiltrative lesions grossly, and revealing papillae, Psammoma bodies, and unique nuclear features microscopically. Despite its malignant nature, it carries an excellent prognosis in most patients, especially when detected early. This image is not just a diagram, it's a complete clinical story, starting from origin, moving through gross and microscopic pathology, and ending with prognosis and variants. If you visualize this flow during exams or clinical practice, you won't just remember papillary thyroid carcinoma, you'll understand it deeply.